the CME, and please register for CME so we can track. Thanks to everyone who's joined. This is a very special lectureship in honor of Dr. Rosenfeld, and I will just remind people before we speak a few moments about Dr. Rosenfeld. The upcoming lecture series, we have a few, this is our Giants in Yale Cardiovascular Medicine series, and we're excited to have other lecturers joining us in the following weeks to celebrate other giants within cardiovascular medicine here at Yale. And hope to see many of you here in person or on Zoom. As our disclosure and accreditation information and information about Dr. Joint Maddox, who I'll let Catherine introduce in a second. But I just wanted to spend a moment just to, to remind everyone of the impact that Dr. Linda Rosenfeld has had on, I would say, on medicine at large, within cardiology and here at Yale. And really, I think we use the term trailblazer very often, but sometimes it basically misses the mark. And I suspect it misses the mark in this case. Just to remind everyone, I know many of you know her, and she's only a few years out of retirement. And I don't think she's really retired yet, because we see her often, and she's having still such an important impact on teaching our fellows on her own time. And we're so grateful, and it's so well appreciated by our trainees. But Linda really was a trailblazer. I was just educated on what Jackson College was about, where she went for Tufts, and at that time Tufts was gender segregated, I guess. But by the time she graduated, it was one institution. And was one degree, and she received her undergraduate from Tufts. She went on to do medical school at Cornell, and at that time, Linda, I haven't asked you, but I suspect you were. It was not a 50-50 class of women, and then stayed at New York Hospital Cornell Medical Center for internship and residency until we were fortunate for her to come here as, I believe, the first woman cardiology fellow ever at Yale, where she completed her general cardiology training, and then was another first, the first EP fellow, period, man or woman, to join our program and start this program. And, I think, we were fortunate for her to stay on and build the EP section, where she had so many important roles, not only including a longstanding tenure as the fellowship director, as well as when I first met her, she was here earlier than everyone else. And I was trying to get here first, but she was always here first when I arrived 5+ years ago, because she was leading our teaching service, the Goodyear service, where she led and really and dedicated a lot of her time to as she moved out of procedural electrophysiology and did that for a long time and had an impact on generations of medical students through that service. So trailblazer in so many ways. I think also her focus was broad in clinical cardiac electrophysiology, and she's still writing papers with our fellows and had an impact on multiple different analyses over the last few years, particularly around the COVID time. And so, Linda, it's really an honor to give this lectureship in your honor, and hopefully we'll become much more consistent. I'm going to introduce Catherine to come up and introduce our speaker. This is the second annual Rosenfeld Lectureship. Erin Mikos was the first, so Karen, you're number 2. And we are going to, we're excited about maintaining this cadence yearly now, thankfully after COVID is over. So with that, I'll let Catherine tell us about our speaker.
Thank you. And I'll just reiterate and say, I know I'm one of many who is very grateful for the guidance and mentorship that I've received from Dr. Rosenfeld, and I feel lucky to know her. Now, moving on, we have Dr. Karen Joint Maddox here joining us. She's Associate Professor of Medicine at the Washington University School of Medicine, as well as Associate Professor of the Washington University Brown School of Social Work in St. Louis. She's also the co-director of the Center of Advancing Health Services Policy and Economics Research. She received her bachelor's degree in public and international policy from Princeton University, and then obtained her MD from Duke University, staying there to train in internal medicine. She then moved north to Boston for cardiology fellowship at the Brigham and did a research fellowship in health policy at the Harvard School of Public Health. She right now has 3 main areas of research focus, all in health quality. The first work is in quantifying inequities in healthcare quality and outcomes. The second area of work is in evaluating the impact of federal and state health policies. And the third area of work regards the ways in which social risk, disability, and frailty are used in risk prediction models for cost, utilization, and clinical events. She's received numerous awards, notably the Secretary's Award for Meritorious Service for the United States Department of HHS, as well as the Lerner Research Fellowship for Research Excellence in Junior Faculty at the Brigham, as well as the Thomas W. Smith Fellowship in Heart Failure Research. It's my honor, and please join me to welcome Dr. Maddox for this celebratory Dr. Rosenfeld lecture.
All right, good afternoon, everyone. Evening, I don't know, when does it turn to evening? 5? Thank you for being here in person and online. It's an honor to be here. Thank you for that kind welcome, and particularly for this very special lecture. See if I can figure out how to move things forward here. Where's the clicker? Mouse. So just click the mouse. That's very straightforward. That's not working for me. That'll work too. Maybe. There we go. All right. So what I'm going to talk about today is why paying for quality hasn't improved cardiovascular outcomes or equity. And this may be a slight departure from some of the research talks that you hear at Grand Rounds. Sometimes you'll have to bear with me for a little bit of storytelling, but I promise that at least much of it is based in data and hopefully will be relevant to your day-to-day life. These are my disclosures. It's largely research support related to this, so I'm intellectually conflicted, if not financially conflicted, and previously received research funding from Humana and served on the Health Policy Advisory Council for Centene. I'm going to start by saying thank you to the folks who make this visit to Yale. I have some familiar faces in the crowd, so some of your near and dear up there. Nihar, one of the smartest co-fellows I have ever had. It made me feel quite incompetent as a second-year fellow to have him walk in and give chalk talks that I could never have done. Tarek, who was the only resident I've ever seen hang out on the cardiology service on his days off. Eric, of course, who I had the honor of observing when I was a medical student run major clinical trials, as I now learn he was a barely junior faculty at the time. Erica, who I've had the pleasure to work with through QCOR, Rohan as well, and now through JAMA. Jackie, who hopefully is listening online, who was a phenomenal resident, an intern I had at WashU, and just a force of nature that I've enjoyed watching her career. And of course, Harlan, who frankly, I don't think my career would exist if it wasn't for him, having essentially started the field of cardiology outcomes research along with a few other folks, and really bringing this type of measurement both into the national arena and into the research world. But I want to think a little bit too about how this lectureship for me reflects some things that I found in an article about Dr. Rosenfeld online. And I found these 2 quotes to be particularly touching, that really resonated with me. Talking really about giving forward, about helping the field grow and training people, and really both connecting with those who have gone before and then maybe those who have yet to come behind. That's something that means a lot to me in my career. It's something that I've benefited from immensely, and having folks around me to be phenomenal mentors. And so I give this lecture in that spirit and in recognizing the folks that have helped me get here, and also for those in the room, online, and in my home institution who I hope to be able to continue to mentor, and hopefully someday will be thinking and thanking me in something like this for having helped their careers start as well. So I'm going to tell a little bit of a story about quality measurement. So for those of you who were not practicing prior to 1950, there was very little quality measurement, but starting in the 50s, there was the introduction of minimum standards, basically. So minimum standards and something called the indicator management system followed by the Oryx initiative. This was JCO starting to go around to hospitals and saying, like, you should actually be doing a thing. We may not know a lot about what the things are. This is before there was a ton of data, but we think that there should be minimum standards in medicine. Now, in the early 2000s, the Hospital Quality Alliance came together, and this was sort of a public-private partnership comprised of insurers and of the government coming together to say, now, systematically, we should be measuring what we do in healthcare, which seems sort of just the norm now, but was not the norm at the time. And so this moved into sort of the era of universal quality measurement. We really started down the path that we're on today of saying everything that we measure, we should do. My slides are automatically advancing, which is a little bit trippy. Turn that off. Probably not. All right, you just have to bear with me if I have to flip forward and backward. So quality measurement probably improved processes of care, or at least documentation. This is data from the beginning of that. This is looking at the first quality measures we had for heart failure. So assessing LV function, ACE inhibitors, smoking cessation counseling, and discharge instructions. Actually interesting, we're not doing all that much better in ACE inhibitors than we were 25 years ago. But this is what the first data showed when we actually started to measure what people were doing. And you can see that particularly for smoking cessation, discharge instructions, there was a pretty big improvement in the early years of this program. So seeing as that was sort of a success, we moved into a more formal quality measurement program where we started actually reporting the data. So now, instead of just telling hospitals, let's look at your own data and figure out what we're doing, the idea became sort of part of the zeitgeist that maybe people would compete. Maybe if we put it out there, you would start to feel some pride in what your hospital did. And so the first data became available around 2004 after the Medicare Modernization Act authorized the collection and basically reporting. Congress had to do that. It became publicly available in 2004. So by 2005, 96% of hospitals reporting. You had to report. It wasn't technically mandatory, but you had to report to get your annual Medicare update, so everyone reported. And this is the reported measures that were in there. Now, I was an intern, I guess, when some of this stuff started. And there was the basket is there to remind me, there was a nurse with a basket, and it had flu shots in it, and it had smoking cessation things in it, and it had order sheets in it. And she would go around and you would sign it, and then all these things would happen. And it was like the most basic quality improvement project. And it was perfect because someone took responsibility for making sure that the things got done. And so sure, there was a benefit in documentation, but I actually fully believe, having lived it, that it was actually associated with a change in the fidelity with which we sort of met the appropriate measures because someone took responsibility for doing it. It was no longer haphazard whether or not these sort of important elements would happen. And so the data would suggest that public reporting probably improved processes of care, or again, or at least the documentation. It's always a little bit of both. You can see in 2003, the distribution of performance on heart failure on the left and pneumonia on the right. And then by 2008, certainly the performance had shifted, right? So more hospitals now were hitting what we'd consider to be, I think, good or very good performance on these things. So I think some meaningful evidence that measuring what we do matters in terms of making sure that we actually do it. But public reporting of the processes didn't improve outcomes. And that's where the story sort of starts to get a little bit more interesting in terms of how this has played out over the last couple decades now. So you can see for acute MI, heart failure, and pneumonia, there was really no evidence that the introduction of this, what we consider to be better care, right? We're doing the things that we should do, was actually associated with a change in outcomes for these conditions. This is mortality rate. In some cases, perhaps even a slowing of the improvement that we'd seen. Now, that didn't dissuade anyone from continuing on. So we went from reporting processes to reporting outcomes. So starting in 2008, we moved to start publicly reporting a broader set of conditions as well as outcomes, and moved into sort of the outcomes reporting era. To make a long story short, reporting outcomes didn't improve outcomes either. So these are some data looking at mortality rates for reported versus non-reported conditions. So we were reporting on acute MI, CHF, and pneumonia, which we still do. The non-reported were GI bleed, sepsis, UTI, sort of a range of, comparable conditions. And it doesn't actually matter which one of those lines is which, because there wasn't either a trend change or a separation in terms of the improvement over time in mortality based on reporting those outcomes publicly. So again, not to let a good idea go untested, We moved on from reporting outcomes to paying for outcomes. So we doubled down again. And by we, I mean the federal government. I'm not actually speaking for the federal government, but that's who has driven most of these programs. So starting after the Affordable Care Act, we moved into the era in which we operate currently, right? Our norms for how we do business, which is largely under these value-based payment arrangements. So when we're thinking about how we're paid for doing our job, much of what we do, we'll see the payment adjusted based on this alphabet soup for readmissions, mortality, patient experience, and safety and costs now, but not initially, based on what these programs measure. So we've taken the infrastructure that we've been building since '04 in terms of measuring all these things and now moved it into a payment program that is a national and mandatory. Well, again, to make another long story short, value-based payment hasn't improved outcomes either. And it's not because the measurement isn't good. The measurement is quite good, and leaders here, including Harlan, have built some really phenomenal ways to use data to get good information about what's happening. But this is hard. And just simply reporting and then paying on readmission rates did not improve readmission rates. There's a little dip at the beginning. I don't know if you have a cursor. So you can see when the program was reported, there was about a 1% decrease in readmission rates for Medicare. And since then, which is 2012, readmission rates have essentially been entirely flat. Every hospital in the country has been working on readmissions in this timeframe. This is not for lack of trying. This is not because people don't know it's an issue. This is not because people don't care. I will get into why I think this is the case. But paying for readmissions alone has not continued to improve our outcomes on readmissions. The top line is Medicare, the rest are other payers, which have been under some mix of payments, and those haven't moved either. And you can see mortality, value-based payment hasn't improved outcomes if we think about mortality either. This is looking at either a composite or the individual conditions, and other than a little signal at the end of pneumonia, which subsequently reversed, there's been no evidence that value-based payment has improved mortality. And we've seen some recent data suggesting that heart failure mortality is actually going up in sort of quite an alarming way. So nothing to suggest that these were sort of the magic bullet that we had hoped. And nothing in these programs addressed access or equity. So if you think about where we see the worst outcomes, the toughest problems, neither of these were addressed by any of the prior value-based payment programs. They just didn't go there. So we will for a moment, which is to say that you can't think about quality and outcomes in this country without thinking about the inequities that are sort of underlying the data that we see, right? So there are persistent and profound and unacceptable health inequities in the country. You can see on the left the gap between Black and white for age-adjusted mortality rates per 100,000 population for cardiovascular disease. And you can see on the right for individuals in Medicare living in poverty or not, so poor or non-poor based on qualifying for Medicaid. Again, this is not because we haven't known about the problem. It has stopped getting better in some cases. And actually, if you look at the rural-urban gap, it is widening rapidly. So we are seeing growing inequities, or at least stagnating improvement in inequities in most of these outcomes. We also know that adding risk factors compounds risk. So this is a map of cardiovascular disease. I'm in a cardiovascular audience. That seems appropriate. I could have put up a map of cancer and it would look the same. I could certainly put up a map of diabetes or stroke, of Alzheimer's, and it would look the same. Now, much of these have common, sort of inflammatory underpinnings, but they also have very common social underpinnings. And so you can see here the heat map of where you see the intersection of rurality, poverty, and minoritized and disinvested communities. That is where we have like 5x greater population attributable mortality from cardiovascular disease. So not surprisingly, value-based payment didn't move the needle on equity either. This is looking at readmission rates for Black versus white, Black patients in, or Black versus non-Black, Black patients in orange and non-Black patients in what I believe to be dark blue. And you can see no evidence either in overall or in lower high performing hospitals that the gap was meaningfully impacted by these programs. We've done some additional work looking at alternative payment models, which is sort of when you take value-based payment and make it even more inclusive in terms of thinking about the totality of the care that you provide. So bundled payments, where you're responsible for a 90-day episode for someone. This is a study that we did looking at bundled payments. And again, you can see pretty profound differences in readmission rates among patients admitted with this set of target conditions. This is 90-day readmission, so they're, almost 40% in some cases. But no evidence that the program changed that gap whatsoever. And even more broadly, all of these payment programs have turned out to be pretty grossly inequitable. So they disproportionately penalize hospitals, clinics, clinicians, facilities that are caring for vulnerable populations, particularly those living in poverty. And you can see here in each of these cases, these are just 5 different programs. The names don't particularly matter. They're just across different payment settings, that in every place that you look, those groups are penalized more than the others for low quality. Now, to some degree, is that low quality? Sure. Some of these places are quite resource limited, and we all know the safety net hospitals that can barely keep the lights on, let alone, start a discharge planning program. But we also know that these groups are not as good at coding, and there's not as good at the administrative parts. And I'll get to that later about why the game is actually part of this story. We also know that these inequitable penalty patterns hold by race independent of poverty. So both hospitals and clinics that serve a high proportion of Black patients or a high proportion of Black or Hispanic patients, especially those that also intersect with poverty, are much more likely to lose money under these programs. And at least I personally think that taking money away from some of these clinics that are really struggling in the first place is not the most effective quality improvement strategy. And consequently, we've seen no evidence that this approach has led to an improvement in the inequities in outcomes. So in summary, I'm not done yet. This is just the middle. Quality measurement and value-based payment as implemented have improved processes, not improved outcomes, and not improved equity. But they seemed like a really good idea, right? And I think we all believe, we're data people, right? We're in cardiology, that you have to know what you're doing in order to make it better. You got to see, you need to know, are we giving people the beta blockers? Are we getting people their screening, whatever it is? So why? Like, why are we in this conundrum? And how can we, as people who understand both clinical medicine and sort of the policy side, think about ways to try to make this better so that we're all rowing in a direction that ultimately leads to better patient outcomes, which is the point. So I'm going to talk about 3 reasons. The first, and I've intimated at this one. So healthcare is hard. And it turns out to often be easier to game the measures than to improve patient outcomes. And you can imagine, I mean, this is sort of true in life, right? If you're given a big penalty about something that you can't really control, you're incented to behave badly. So I don't know if anyone remembers the VA waitlist scandal, where essentially clinic administrators were put under a ton of pressure to reduce wait times. Now, these people had no ability to reduce wait times. They weren't the ones delivering the care. This wasn't a problem that they could fix. So what did they do? They fixed the lists. They started keeping paper lists instead of keeping lists in the medical record so that they wouldn't be penalized for something that was beyond their control. And you can hardly fault them for making that decision, although it turned into this sort of whole scandal that led to a lot of changes in veterans care. That's a talk for another time. But it is normal behavior, if it is very difficult to do the right thing, to be tempted to do the thing that may be easier and not as beneficial for patients. Number 2, failures in the other part of the equation of health, access to care, have made gains and outcomes elusive. And we'll talk about that explicitly in a moment. And then finally, health is only marginally determined by healthcare. And if we don't recognize that, we're actually missing an opportunity to think more broadly about how we can help patients. Okay, so back to this slide. Healthcare is hard. People are complex. And oftentimes people talk about medicine as being like flying a plane, right? We need to be like the pilots and have our checklists and all that. I don't disagree that we should keep track of what we're doing, but like every person is different. There's no standardized plane. There is no plane. There's like, I don't know, a biplane and a Cessna and a jet. I mean, there's all sorts of different things, right? And so the idea that there's one thing that you could do with full fidelity that would then impact outcomes perfectly just doesn't make sense for people. Reporting quality turns out to be a lot of work, especially if you want to look good, which is sort of the catch in all this. So the data on the upper left is some data that Larry Castellino got from practices, looking at the total effort in terms of hours per week per physician FTE in a clinic that was being put into collecting quality information. So that's 15 hours per week per FTE of mostly administrative staff time to do things like enter information into various report forms for the 17 different payers and all their different quality measures. I mean, that's preposterous. And on the right, you can see data from Hopkins. So a system much like mine, much like yours, a big, highly functional system. And they did time-based costing analyses and found that it was taking, this is a log scale on the y-axis. It was taking in the hundreds of thousands of person hours and tens of millions of dollars for these different types of measures to report them. That's not to do anything to make them better. That's purely the administrative infrastructure to report this stuff. And interestingly, the claims-based measures were the most expensive. And I don't know if you all have this, but we have this, we have a building of coders. No claim goes out the door until it has been reviewed, I think twice, to make sure that there is no hospital-acquired condition in there that shouldn't be, that every comorbidity is captured, and that we are doing the maximum we can from coding in order to get the maximum reimbursement that we can from quality, which again is not, I am not disputing that approach. I would like for our hospital to get paid too, but it is a lot of work. There are currently more than 200 quality measures in the outpatient value-based payment program alone. This is very different than that list I showed you of like beta blocker, ACE inhibitor, and like check someone's EF. This is a lot of things, and having the infrastructure to be able to even just measure all this has created an unbelievable amount of complexity in healthcare. So what has that led to? A pretty shocking rise actually in the administrative costs of healthcare. So you can see healthcare administration adjusted for inflation on the right, having grown 1,553%. And you can see on the left and on the right, you can see a graph that demonstrates that we've had a multi-fold increase in the number of health insurance claims processors in this country. This is Labor Department data. And hospital administrators with a very slow growth in primary care physicians, who I would argue are the bedrock of our healthcare system. So we've managed to build this enormous administrative umbrella over the top of the care that we deliver in, you know, a few decades. We're not, most of the growth has really been in the last 10 to 15 years. And vertical and horizontal consolidation are sort of the natural thing that follows, right? So can you exist in that environment as a small independent practice? You cannot in most places. And so in cardiology, we have seen that we've gone from 10% employed or integrated to 90% between 2008 and 2022. That is a massive shift. This is a complete redefinition of what the cardiology workforce looks like, right? We've moved to a completely different set of business models over a relatively short time frame, not only because of value-based payment, but because of sort of the entire empire of things that comes with the business of medicine these days. And corporatization is next. So cardiology is of growing interest to private equity firms. And what private equity firms typically do in a market is go in and buy an anchor practice. They use that anchor practice to buy up the other practices, and then they raise prices, and then they exit, and they've made money essentially by increasing the value of a practice. That doesn't actually make people better. Now it could. I think we have plenty of inefficiencies in healthcare, and private equity, I think, has shined a actually somewhat helpful light on the ways that disruption can be positive. So we should learn from this. But private equity has gone in and completely disrupted the dermatology and ophthalmology markets around the country, and it is coming for cardiology. We have a lot of money in cardiology, and we're not particularly efficient at getting it. And so it's a very appealing place for private equity to come in and try to do something with. I'm not someone who thinks that there's nothing to learn from this. I do worry that this is a very, very, very profit-focused model and not necessarily what's best for our patients. Okay, so that's problem one. Healthcare is hard. Problem two is that health outcomes are not only about healthcare quality. So this is a, I think, fairly useful schematic, actually, that says if we want to think about what makes health outcomes, length of life and quality of life up at the top, and that sort of works through policies and programs, health factors, and up to health outcomes, what are the things that this includes, right? And so you've probably seen this in various schematics where it's like how much of a person or a pie chart or something like that. But the rough estimates are that about 20% of health comes from clinical care. And we'll focus on that 20% for a minute. Okay. So leaving the rest aside for a moment, which we'll get back to, 20% from clinical care, access and quality. So I would argue that clinical care is the easy button, right? People are right in front of us. There you are. I'm going to make sure you get your beta blocker. Compared to all the rest of it, like this is ours. We should own this piece, and we have owned this piece. But the other half of the equation, when it comes to the piece that we control, again, leaving aside the other parts for now, is access. So access to care is crucial. We can't give you high quality care if we don't see you and touch you and talk to you. And that's a big part of why, despite a lot of work on the quality side, we're failing to move the needle for the population. So in this country, we accept as normal that people have no health insurance. Like, that's not normal. It's not okay, but it's just the way that we do business here. And so we accept that this is normal. And you can look at this graph here and you can see this is broken down by sex and by race, ethnicity, and by age. There's a lot going on in this graph. But if you look at the left, you have men from the ages of 45 to 54, and you can see uninsurance rate. So people who lack insurance, so higher is worse. The blue line is people who identify as white. The orange is Black, and the tan is Hispanic. And you can see that in this group, there's 30% uninsurance rates in the Hispanic population, in the 20% among Black individuals, and say 10 to 15 among white individuals. Now, that changes as you go across the panels here. So if you go over to the right, like this looks very different, right? So why does that look different? Because we have collectively decided as a country that once you're 65, you deserve insurance. And so you may have it. And so when you get to the 65 and up, we have very few racial and ethnic inequities in who has access to insurance. And largely the differences are due to immigration. So you have to work a certain number of years to be able to pay in, to qualify, et cetera, et cetera. And so some of that is related to policies around what you have to do to qualify. But everyone is sort of statutorily allowed to have access to insurance the same way. So the other thing that you might have noticed is that in the middle of this graph somewhere, there's a dip, right? So that was the Affordable Care Act. And I've talked a lot about why I think that the quality half of the Affordable Care Act was largely not effective. The access half was actually quite effective. And we have excellent data to suggest that we have made a meaningful difference in people's health and outcomes based on that. So about 2/3 of the gain, that drop in uninsurance, ignore the blip back up in 2020 for the time being, was Medicaid, which I'll talk about. The rest was the exchanges, so people call Obamacare. It was basically the invention of a marketplace such that if you were working for a small company, you didn't get insurance and you wanted to purchase insurance, you could go do so. That actually really didn't exist before the Affordable Care Act because there was no risk pooling. So a company could say, sure, we'll give you insurance for $50,000. It's not useful for most people. So the exchanges were people purchasing their own insurance, but on a risk pooled infrastructure. Okay, so that was about 1/3 of the gain. The other 2/3 is Medicaid. So Medicaid expansion as of February, I actually don't think it's changed by now, but this is the last time Kaiser put their map up. You can see the status of state action on the Medicaid expansion decision. So Medicaid expansion was supposed to be national, and then states sued, saying it was essentially a violation of states' rights to be forced to spend this money because states can't deficit spend. And so consequently, we have a map of coverage that is quite regional. You can ignore Wisconsin. They're actually kind of an early expander with fairly generous coverage. So everyone asks about Wisconsin. They're mostly an expander, so ignore them. The map intersects quite explicitly with a lot of the places where there are the worst health outcomes in this country, right? So this is not making things better, this pattern here. And to put some specifics on it, so in Missouri, my current home state, before Medicaid expansions, we were a late expander, expanded by popular ballot. You had to, A, have dependent children. So if you didn't have dependent children, you didn't qualify. There was no pathway to get Medicaid. And B, make less than $2,400 per year. And you had to have less than $2,000 of assets. That is poor. You can't get a part-time job. You can't have like a car at all, right? And still qualify for Medicaid. The idea that someone who's making $2,500 a year and has a $2,500 car is going to go purchase insurance with that money is insane. That's not a very professional word, but it's not reasonable. So this was essentially leaving an enormous group of people without access to insurance coverage, right? It's just not feasible for people to buy insurance. It's not a moral failing that they didn't go buy insurance. It is reasonable to not buy insurance if that is your income and asset. Now it's better. So currently, Missouri is now a standard expansion state. So we use the same cutoffs as essentially the rest of the country, minus some more generous states. So with or without children, individuals qualify up to $20,000 in annual income. That's still not a lot of money. Probably goes a lot farther in Missouri than it does in Connecticut, but it's still not a lot of money. And so we're seeing a lot of people who are still unable to purchase insurance. But I can say clinically, this has been a game changer for me. Being able to get people on Medicaid and discharge people with some access to medications and to care has been a huge difference for us in the past couple of years. Because of the different choices by states, insurance remains quite different across states. Texas has far and away the highest uninsured rate. That's a combination of immigration and policy. Missouri is somewhere in the middle. Connecticut is the tan one, kind of down here, I believe. Yeah, right there. And so you can see that across the country, we have really, really different sort of rates of uninsurance just in the population. Massachusetts is the lowest. They were Romney Care before it was Obamacare, and they expanded quite early. So that they have a decade head start on everybody else and really have quite a good infrastructure for getting people covered. So the effects of Medicaid coverage expansion, unlike the effects of some of the quality measurement stuff that I talked about, have been essentially unmitigated success. So there's financial protection of individuals and hospitals. So rural hospitals close less in states with Medicaid expansion, which is why the North Carolina expansion and what was almost the Mississippi expansion have had the business community behind them and the hospital community behind them. Hospitals can't stay open if they don't get paid. Medicaid expansion is associated with greater access to primary care, ambulatory care visits, prescription medications, all the things we'd want people to do to stay healthy, better adherence, more access to preventive services, better self-reported health, better mental health starts as soon as you get covered because it feels so bad to not be covered, but is also associated with more treatment for mental illness. There's mixed evidence for utilization. Emergency departments use tends to go up. I think that's probably how it's supposed to work. But this was initially held out during the Oregon experiment as evidence that it was failing. This is what we want people to do. If you have insurance and you've had a breast mass that you've been ignoring, or you've had a knee that doesn't work, like go get it checked out, or the chest pain that you've been having. And so utilization tends to go up, particularly right after people get insured. We now have pretty good evidence for lower mortality, including infant mortality, arguably the most important kind of mortality we could prevent. But also cardiovascular and cancer mortality, and not surprisingly, impacts are largest for racial and ethnic minority communities and in rural areas where we saw the greatest bump in access. You can see some data on the right looking at heart transplant, demonstrating that Medicaid expansion was associated with an increase in access to transplant, particularly among African-American individuals. We're doing some work on the Medicaid unwinding and the public health emergency. The public health emergency let people stay on Medicaid. It is now unwinding. We found that the public health emergency with increased coverage is demonstrating, again, a bump up for individuals identified as Black, Hispanic, American Indian, Alaska Native, Asian, or multiracial in terms of access to transplant. So these things do matter. Beyond coverage, we also accept as normal that healthcare bankrupts people. It's the most common cause of bankruptcy in this country. And so people avoid care due to cost. These are data breaking it down by race and ethnicity. But I would argue that every number on this is too high, right? If you're avoiding seeing a doctor, delaying care, not having a usual source of care. And one group for whom this is quite salient is our heart failure patients, who at the same time as they have seen an explosion of medications that can keep them healthy, they have seen an explosion in the copays required to access those medications to keep them healthy. And so we're seeing real difficulties in people being able to get access to these meds. Now, this is getting better. Everything becomes generic. No one could get Plavix when it first came out either. But in the current moment, we're seeing a lot of people struggle with this out-of-pocket cost that can be over $5,000 a year, especially for folks on limited income. That's a tough choice to have to make to get your heart failure drugs. Physical access also matters. So hospital care in this country is quite segregated. This is some work we did looking at racial segregation in current hospital care. And you can see the most segregated hospital referral regions based on, there's two different indices of segregation, dissimilarity, and the isolation index, but you can see some of the same ones up there. So Detroit, Washington, St. Louis, Indianapolis, Minneapolis, Chicago, Baltimore, Memphis, and areas where you see higher segregation, particularly on the isolation index, which is a more volume sensitive index. You can see that Black patients in particular do worse when care is more segregated, right? So we have coverage access issues, and we have physical access issues in terms of sort of who gets into the hospitals. We also know that rural areas lack access to outpatient care, particularly specialist care. Rural primary care is actually not that bad compared to population need. The folks who are remaining in rural practice tend to be in primary care. It's tough to come up with a model to get specialists into rural care. There's inadequate volume and inadequate support. Telehealth is one thing that could help this, for example, but it was not a norm prior to COVID. And so you can see pretty big gaps in access to specialist care in rural areas. We clinically certainly see it, you guys probably do too, of folks coming in way too late with things that weren't recognized or diagnosed in rural areas because of a lack of access, and that's associated with worse outcomes. Okay, and so the third reason I think that we've not seen improvements in outcomes in the last couple decades, despite a lot of effort, is that health outcomes are not only about healthcare at all. So I sort of teased this before. Health outcomes are also driven by health behaviors and social and economic factors and the physical environment. And actually the majority of health outcomes are driven by health behaviors, social and economic factors, and the physical environment, right? And so why do we differ in these? Well, because people are born into situations in which they are starting off at a different point for a lot of these things. By the time someone reaches us with their heart failure at age 45, or their accelerated hypertension, or their heart attack, or what have you, a lot of this is written. We can do whatever we want to try to make it better, and we should do everything we can to make it better. But a lot of this is written by where people are born. And we have set up a scenario in which many of the contextual factors that surround people are the things that are ultimately driving their health. And we need to at least talk about that. We could acknowledge it's hard, but we need to at least talk about the degree to which this is true if we want to change the conversation around keeping people healthy. So we see striking differences in cardiovascular risk factors by income, education, and rurality. So looking at the middle, for example, hypertension prevalence for folks with a less than high school education is over 40%. For those with a college degree or higher is under 25%. You see similar really big gaps for diabetes, a little bit less for cholesterol, but for coronary heart disease and AMI. Rurality is on the right. That goes obviously the opposite direction. And then income on the left with a little bit of a less clear initial difference in 100 and 200% of federal poverty, but the wealth gap continues to go up. We also know that racism and discrimination drive physiology. So these are things that people experience at a very young age. They are part of the way that they grow up. And we know that racism, as opposed to race itself, has been a big driver of what we see as these inequities. And you can measure the physiologic impacts of these things, right? And it actually happens to white people too. They may be much less likely to be discriminated against, but when they are, they have the same physiologic reaction, right? So this is something that we can see happening in people's bodies. And it happens usually before they make it to us and until we start thinking about how to make their care better with their beta blockers and their ACE inhibitors. Again, nothing against beta blockers and ACE inhibitors, but it is to say that much of this is happening before we come into this as cardiologists and start to think about how to make it better. And to get to the bottom bucket of sort of environmental factors on that prior slide, housing, transit, air quality are largely related to historically racist housing and development policies too. So this is a graph of, on the top, you can see Black versus white individuals and the deprivation index of the neighborhood in which they live. So the Black patients in red, and this is from a data set that oversampled Black individuals, which is why the red bars are so much bigger. Black individuals were more likely to live in neighborhoods that were highly deprived. So in environmentally poor areas near factories and what have you, than white people. But again, Black and white individuals had the same hazard of heart failure associated with the exposure. Black patients were just more likely to be exposed. And in fact, if anything, white patients had more of a decrement from being in those deprived areas. So all these things are coming together to create health in a way that we then see in physiology when people get to us. Okay, so can we talk about solutions? Because I can't imagine that was the most uplifting conversation that you've heard in a while. But I really do think that having the conversation around this stuff allows us to start thinking about ways that we can take what we already do and what we already care about and try to turn this into a way in which we're getting better outcomes for all of our work. So let's return to first principles, like what matters to patients? It's health, right? It's not the PCI, it's avoiding the PCI. It's being with your family and your partners and your loved ones and, you know, getting to age the way that you want. All of this is health. And so if you reframe to how we can move our health systems to think about health, as opposed to only about treating disease, we can actually do what we want to do too, and what our patients want, right? Keep people healthy in the first place. So policy solutions to improve care delivery have to honor values beyond the checkbox. These things are too easy to game. And there are multi-billion-dollar corporations out there gaming. That's always going to happen. Everyone's going to teach to the test, take whatever the phrase is. So we have to actually name the things that we want to happen and try to make those the things that you do in order to win the game. We can't rely on goodwill to get us the things that we want about relational care. So things like belonging and relationships and wellness, I will grant you, are very difficult to measure in a checkbox, and maybe you're not going to go into a payment program, but what gets you there? So it's team-based care. It's longitudinal care. I was talking with Eric about why he lives heart failure. It's relationships. It's being able to connect with people longitudinally. It's the nurses and the social workers and the pharmacists and the care team that makes people feel like they belong, that reaches out to say, how are you doing? I noticed you didn't refill your medication. Is everything okay? Community-based care. We have a lot of money in big health systems, and putting more and more money into big health systems to help them play this game is not the way to get money back into the community. You want to make housing more expensive, you can launder it through a health system, right? We need to get money directly into the community to address these issues and let the community decide how they want to spend it. Not that the health system can't be involved in doing that. We have money, but we cannot be the ones who own all the money to keep people well. And we need to very explicitly and intentionally develop clinicians from excluded groups and areas. And that means based on race, based on ethnicity, based on morality. And it means not just doctors. I don't know that we need all that many more doctors, but we need a lot more community health workers and pharmacists and nurses and teams to make sure that people can be kept in good health collectively. For the more policy wonky among us, I think there are actually very specific policy decisions that could be made that could lead to some of these changes. We could prioritize and reward access. We don't measure access. We measure what was your mortality rate among people who got a cabbage. We don't measure to whom are you giving cabbages, and to what degree does your patient population getting a bypass surgery look like the patient population that you serve. And instead we've incented going and finding the healthiest people. You can change the metrics. You can change the metrics to reward access, to think about outpatient care, and to focus on the high-risk groups. If I tell you you have to meet a certain proportion of patients at a blood pressure of 130/70, you're going to go find your patients who were 132 last week and give them a cup of tea and remeasure, and you did it. If I tell you that you need to get your average clinic blood pressure down, you're going to go find your person who is 210. You're never going to get that person to 130. It's not going to happen. But if you get them to 150, they're not going to have a stroke. And that seems good, right? So we need to be more sophisticated with how we think about incenting people to go find the people that need you. Don't go find the people that make your metrics look good. And that's just setting up metrics differently. We need to provide resources to historically marginalized groups rather than take them away. If I were in charge, which I'm certainly not, I would revamp much of current value-based payment and replace it with population-based payment that focuses on high-risk patients. I don't think these penalties have done what they were very appropriately intended to do. I think it is largely a failed experiment, and we need to think about better ways to improve quality in the places that are struggling the most. I don't want anyone to think that I don't believe in data. I very much believe in data. I love data, love spreadsheets, but they have to be baked into our norms and then let us figure out how to go make them better. The sort of ticky-tack, we must measure every little thing and get it in a spreadsheet and then submit it to CMS and then have them pay us 3 cents more for this 3 years after the actual clinical care happened is not driving quality. And so we need to think about ways to get that quality measurement turned around faster, back to people in real time, and actually improving care as it goes, as opposed to being a gameable situation later. And we need to leverage clinician and patient engagement instead of thwarting it. So who in this room would sign up as a patient or a clinician for a program that was going to cut costs? Nobody, right? I don't want to cut costs for my patients. If they need something, I want them to get it. And I certainly don't want you cutting my costs. If I need something, I would like to make sure that I can have it. But how many of you would sign up for a program that was going to improve diabetes care nationally? What if it was National Diabetes Year and we were going to work together to improve diabetes? Like, that's a very different starting point. You can do the same thing, but telling people that you're going to cut costs, and that's the whole point of the programs, has not gotten people to the table to try to work on these programs collectively. And setting them up as competitions against each other where there's zero-sum games is not the right way to get people to share best practices. And then to go fully beyond the areas in which I am expert, we really do need policy solutions that are bolder and broader. So the inequities that we see are not accidents. People created these things. People can uncreate these things. We need structural solutions to things that are going to actually make a difference in the long run. I think health is a public good. And during COVID, I think people started to recognize that a little bit. Like if you were close to other people, you would get their disease. But it's like much, much broader than that, right? We're all collectively better as a society when we're healthy. There's a moral argument for that. And there's actually a pretty strong economic argument for that. So states that have expanded Medicaid, for example, and have seen gains in health, have seen economic gains and reductions in criminal justice costs and all the things that come with healthy people. And so either of those arguments, whichever works for you, is fine with me. But we need to think about the public, or we need to think about health as a public good. And again, way beyond my expertise, but economic opportunity. So education, housing, jobs, criminal justice, the tax code, we all feel morally superior when we check the box for our mortgage deduction. But people feel morally inferior if they get that same amount of money to help them buy food. How is that a thing, right? We've created these structures that we all think are quite normal. And in fact, they're quite rigged to not help people stay healthy. And they're in many cases doing everything they can to keep people from getting healthy by creating these multi-tiered systems. And we need to talk about that as healthcare professionals to say, this is about health. This is about keeping people well. And we want to be part of this conversation. So in summary, health reform focused on paying for quality has not been successful in improving health over the last 15 years because it's focused us on the wrong things. Check boxes at the expense of relationships. And it's not a measurement problem. It's an implementation problem of what we've done with the information that we have. Administrative burden and financial pressure have driven our health system in the wrong direction. And we need to very explicitly, I think, as clinicians, combat that and say the patients still matter. And whatever the sort of corporate pressures are that happen, that's going to happen. It's not going to go away, but it means we need to be louder about why the patient is the center of all this. And finally, the things that drive health are much broader than healthcare. And so recognizing that, addressing it where we can, and at least being part of the conversation about why patients deserve access to those things is important. You know, health policy I see as a tool. It's one tool. There's clinical trials, there's basic science, there's clinical care, there's education, there's all different ways to make the world better, right? To make things better for our patients. And health policy is one of them. And there's not a lot of clinicians in health policy, but it feels, when I round, I feel quite connected to health policy, actually. It's reflected in the faces and the blood pressure of all the patients that I see every day. And so I think it is a tool. We should be using it, and it can be used to reduce inequities in cardiovascular disease, but we have to use it the right way. And I think we have a little bit of room to go. So thank you very much for your time. Thank you for making this possible, and I'll take it.
Karen, first of all, thank you so much for this, really inspiring and educational. I learned, I can't even speak to like all the things that I learned for the first time listening. So maybe I'll start this conversation off a little bit, and then glad to pass it on. But one of the things that I kept on coming back to as I was listening was the unintended consequences of what we might put out there in the world as relates to policy. I think that was that's what I interpreted a little bit around some of the value-based purchasing and some of the kind of, and maybe it's the way I'm built, but I was like, gosh, why couldn't we have evidence from a randomized trial that this was going to be the consequence we could have expected and we could have proven it? But we can't wait for, trial after trial to test policies. So have you thought about how to do rapid cycle changes as it relates to policies? Can we put more policies into play and test them more frequently? And how can we do that?
Yeah, so that's a fantastic question. So it actually is possible to do randomized trials in policy, but there have only been a very small number. So there have been 2 that I can think of, and another one is launching next January. So when the Center for Medicare and Medicaid Innovation started, which is the people who have been doing a lot of the experimental versions of this, these were big mandatory programs. They should have had a DSMB, agree. CMMI wanted to do this sort of testing, and it is quite hard, but they've managed to randomize a couple. So they quasi-randomized something called CJR, which is the Comprehensive Joint Replacement Bundle Payment Program, and they randomized a home health value-based purchasing program. So it can be done. Typically what they do is cluster randomize like a state and then run it for a couple of years. And then home health value-based purchasing they thought was reasonably effective. I can argue about that, but it looked like readmissions went down a little bit. And so now they're scaling it. So they can. The rapid cycle, the rapid cycle thing is a fascinating idea. I hadn't thought about that actually. It is so contrary to how the government works. They wrote these things in statute, right? I mean, it said there's a law that says there shall be a hospital readmissions reduction program. It shall penalize hospitals on such and such. It's literally law. It will keep going until Congress makes it stop. So that is not baked into how they do it. But I love the idea. And I think it would be great thinking through what CMMI could do to try to do more adaptive trials in that space.
Can you hear me? Oh, okay. Thank you for that incredible talk. Sort of putting like an ethicist frame in it, as I like to do. I think you've made a very compelling ethics argument, both for sort of the deontologist. You made a very good categorical moral approach for why it's our duty to improve access and make structural changes, because we can see through the data the effects that this has had on individuals. And you also make for the consequentialists, you make a great utilitarian economic argument for why this is better for everyone else. And yet I feel like there's so much resistance politically, and in many ways socially and culturally, because of that's a very deep kind of, I think there's this long-standing culture of individualism, a culture of sort of a rescue ethos rather than a preventive ethos, and but without getting too far into those weeds, how do you think you make such a compelling argument, and yet it feels like there's so much inertia and resistance, and how do you think that we can take this and change minds? I know that's a really, really hard question.
I'll try.
But I'd be really interested in your thoughts, because it is so compelling. It's like so obvious, like these are the things we need to do, and yet this isn't a new problem.
Yeah.
So
I'll give you 2 examples for Medicaid expansion. Activism and capitalism, which are different.
Mm-hmm.
So Medicaid expansion after the initial expansion has happened in 2 ways. One is the popular vote. So there have been groups that have gone around and gotten the number of signatures they need to get Medicaid expansion on the ballot, and it has passed. That's how we got it in Missouri. Forgetting what other, I think Oklahoma might have been a ballot measure. They were working on it in Mississippi. So there is a certain amount of activism among people who just say, we think that morally this is what we should do. And that has been successful in some states. But the reason it works is because of capitalism. So when Medicaid expansion passed in Missouri, the governor, I was going to say I'm not being recorded, but of course I'm being recorded, but hopefully the governor of Missouri is not watching this. The governor of Missouri made a very performative show, that's a very performative opposition. He actually knew how much money the state was going to get with Medicaid expansion. Our senator did the modeling. You can see how much money you will get. But he needed, for political reasons, to put up an opposition. But it was sort of a soft opposition. And when the state, someone sued, and then the state Supreme Court, and anyways, it took a while, it took a year to get passed, but it eventually went through because he let it go through, and the politicians, the ones sort of in the middle, let it go through because ultimately the economics of it were good. So my general thought is that for these things to work, you need the moral argument to get people on board, but you also need to be able to make a pretty straightforward financial argument for why it makes sense. And in a lot of these cases, we actually have it. And so I think we need to come to the table with data and say that, you know, this is what we think is going to happen for something like Medicaid expansion. For some of the others, it's trickier, but we are generating better and better data, to your point, about some of the there was a review article, for example, around like disease management trials and figuring out what parts of it are good. Okay, so then you can put a dollar amount on that. Then you can say what that costs, and you can talk to Congress about what we're going to save. So you have to give the moral argument and acknowledge the politics, and then come up with an economic argument to actually get policymakers to do anything.
Great. Thank you.
I really enjoyed your talk. Thank you. So I've been thinking about the topic of your talk and this discussion about equity and equality, and whether, so there is so much inequality within the society in every aspect, many of them you mentioned. And now we're talking about healthcare, which is 21% of your outcome, determines 21% of your outcome. So should healthcare go after addressing inequity, or should the goal of healthcare be equality? I.e., so for example, here to see a cardiologist, you have to wait 60, 90 days, yes? So should you think, and it was in one of your conclusion slides, that there should be resources dedicated based on the type of population that you're dealing with? Should this be the rule, especially in this country where, you know, there is a big opposition, half of the country votes differently than the other half? Or should the focus be really on equality, and then everybody would be on board?
I mean, I sort of wish I could throw that question back to the ethicist, because I do think it's a strategic question, right? So if you take as a given that we can make things better, I think one of the more non-controversial ways to make things better is by making things standard. And interestingly, if you look at other countries, so we have obviously our health system is not a system. It's all this sort of economic activity running around. You can go all the way to like the UK, which is like the VA, right? It's the payer and the provider is the same, but most countries aren't that. Most are government ensures that everyone gets care, and then the private market provides it. And in those places, you see that in most countries, you've got, say, 70% of people covered under a public plan and then 30% purchased private. And it creates a very different approach to equality and standardization, because it's sort of like public education, right? If the more people that are in it, the more that you try to sort of lift the whole thing. So there is some argument to be made that you don't need to choose between things. You just need to try to make things standard and fair. But I'm not totally sure how to answer your question with a one or the other, because politically, sometimes things are feasible and sometimes they're not. Clinically, it's much easier to talk about standardization than it is to talk about reducing disparities. People get uncomfortable when you talk about discrimination and bias. People don't get uncomfortable when you say, let's make sure that everyone gets a beta blocker. So if those things get you to the same place, then let's talk about the racism and the bias, but let's also put the thing in place to make sure people get their beta blocker. So I think it depends on how pragmatic you want to be. I tend to be a pragmatist and a little bit of a capitalist and sort of say, well, then change the incentives and just sort of get it done, however it is that you can get it done.
Thank you.
So I think with that, I really want to thank Karen for a phenomenal lecture, and again, honor Roosevelt for her contributions. Thank you. We have about 40 non-people on
Good.
Never know if they have one.
Yeah.
They're monitoring it, yeah, I know.
With,
Look at that.
They're out of luck.